I'd like to acknowledge the traditional custodians on the land in which we're meeting today, and I pay my respect to elders past, present, and emerging, and to any Aboriginal or Torres Strait Islander people that might be on the call with us today. I'd like to extend a warm welcome to Dr. Gregory Gaughran. Dr. Gaughran is a medical oncologist based in Melbourne with a special interest in the treatment of upper GI cancers. He will be discussing personalised medicine and how it relates to access to clinical trials. Personalised medicine is an innovative approach that tailors cancer treatment based on specific information about an individual's tumour, allowing for more effective treatment decisions. During his presentation, Dr. Gaughran will also highlight the free tumour testing available for patients with upper GI cancer through the OMICO program. He will talk to us about comprehensive genomic profiling and the role in upper GI cancers. So over to you.
Thank you. Thanks all for tuning in, and for any that will watch it later as well. So as Alison said, I'll introduce you a little bit to what OMICO is, and just think of CASP and OMICO as more or less the same thing. They're just different branches of the same company, basically. What it is we're testing, obviously, I could focus on all upper GI cancers. The issue with that is that it's probably starts to get a bit too much for one session. So I'll focus just on pancreas cancer. And then a little bit on what you need to know to empower yourself, and to what aspects from a pancreas cancer perspective you should be focusing upon, because there's a lot of information here. And so you don't need to know all of it, but you should make it your business to know some of it. So thank you very much to Pancare. Thank you to the OMICO team and all of the lovely nurses and doctors and healthcare staff that are looking after all of you. And then obviously, of course, thank you to yourselves and for supporting this program. So I just always put this on: if it doesn't challenge you, it won't change you. This is difficult stuff. I don't think this is meant to be easy. I'm definitely going to bamboozle you at times. I don't mean to, but it's kind of just what happens. Think of this a little bit like your first session with your oncologist, where they were saying all these funny, stupid words, and you just, you eventually got to know them. You eventually understood the words, but they're not words you meet in the street. Everyone kind of knows what genetics is, but I think the big thing to distinguish here is there are genetics that come from your mom and dad, hereditary genetics, right? So genetics, that's why you look like you and you don't look like someone else. Right? You get genetics from them, and they could, possibly some of you, this may have happened to you. Sometimes you can inherit risk for pancreas cancer from your mom and dad. And we do look at that, but that's less of a focus. Then there's genetics within the cancer. So obviously, when you were born, you didn't have cancer, right? And when you were 18 or 20 years old, you didn't have cancer. At some time or point, that cancer developed. And that cancer developed from genes going wrong in cells that are no longer you anymore. They're different. I mean, of course, they're not you. They're trying to annoy you and harm you, right? They're different cells to you. And those cells have different genes to you. They're not the same as you. And we're trying to find them different genes. And some of those different genes have targets. We can use those targets against the cancer. We've got drugs for those, and not everyone has them. And not everyone, not all of the scientific community has developed drugs for each one of these genes that go wrong, but we have developed drugs for some of them. Some of them are in really good development. Some of them are already basically ready to go. Some of them are pretty decently effective already. but they're in trials, and some of them are a lot more experimental and are in trials. And so that's basically what we're trying to do here. That's the main nubbin of it all. We've done 25,000 cases of this so far, so we're getting pretty good at doing this, at finding out genes. We're developing our technology as we go. Every year we're getting smarter. We're bringing a lot more trials to Australia. That, you know, there are multiple trials companies now that have told us there's no way we would have come here. There's no way we would have done a trial here in Australia, but you're here. And it's obviously also due to the support of patients and the fact that they're trusting this, and they're participating in these trials, but also just generically doing the test and benefiting from it, and contributing to the group. We will in the future have different directions. It's important that we continue to learn and move with the times. So there's going to be different focuses that we'll have, and one of our big things is trying to drop disadvantage among cancer types. And, you know, I don't want you to all kind of rail against breast cancer, but one of the reasons why I think it's really important to have a group like Pancare advocating for upper GI cancers, that they do not have the same focus placed upon them as breast cancer, and they need that voice as a group, right? And so our focus in OMICO is also not to ignore breast cancer, but to lift up other cancer types, such as upper GI, that don't do as well and that don't have as much research and need more research and more support. So why does it matter? So if you take a patient of mine, they come into my hospital, I don't have any genetics I can give them. I can't check their genetics. I can't check whether they inherited something from mom and dad, and I can't check the genetics in their cancer. I can't do either of those two things. All I can tell them is it looks like it's pancreas cancer. Probably it's the same type as normal. 90% of the time, that's right. Sometimes it isn't. I don't have any ability to tell that. I can do a little bit of staining on the sample that maybe sometimes helps, but basically I have to just treat everyone the same. I don't have any ability to be different in any way unless I use a program like this. This is currently the best program that's available for genomics, even if you were to pay. And the kind of average pay is about 1,500 to $2,000. So this is free, and it is better than those programs that are that expensive. What we also do is address rural disparity to try and improve health outcomes. So we have been very happy to see the exact uptake of rural patients to urban patients in our program. We have exact representation, and we have exact representation of Aboriginal patients, of Asian patients, of poorer economic backgrounds. We are a complete mirror of what Australian society is. And we have also been very pleased to see our colleagues getting smarter. So we have created all manner of different new Australian bodies that are improving research in this area. And we are, again, not downplaying breast, but we are lifting up rarer tumor types to try and improve research interest in that area. I don't think I'll talk too much about this, but basically it's a great big panel of genes that we look at, 500 plus genes in your cancer. We can also have a guess as to whether or not you've inherited this cancer type. That's not absolute, but we can have a fairly red hot go at that as well. And then when we've done all of those genes on you, we've checked all of those genes to see whether you've inherited something, and then to look at your cancer, which is completely separate. The genes in your cancer is completely separate. We then try to match those genes to trials. So if that cancer has that gene, what drug do I have that could attack that gene? What drug do I have that would attack that gene if this gene wasn't also present? That second gene's there. Okay, I won't give that drug. I'll give this drug instead, right? And it makes it a lot more precise. Look, I'm talking as if this is going to happen for everyone. I have to be frank with you; it doesn't happen to everyone, but it's a good proportion of pancreas patients. And you'll see in a minute. I'm going to give you the figures. What's the chances of actually finding something? Is this all too hairy, fairy, arum, scarum? The 3% of people are going to get this, or is this actually worth while doing? That's just a list of all the genes. Another thing to be upfront with you about, it takes a while. It's 6 to 8 weeks return. That's quite a long time waiting for something. Why does it take that long? A lot of it is due to the local lab having to put other priorities above research. And so that takes a big delay. Another big delay is actually with the patients. So they'll sit on the consent for quite a while. So I have quite a lot of patients that will not consent to the program. They're happy to do it, but they won't give the consent for the program for maybe 3 or 4 weeks. And then I find out later, oh, they haven't even consented yet. So the sample hasn't even been mildly looked at yet. They don't kind of get the fact that if they don't say yes to this, it just sits there and nothing gets done. So that they're probably the two biggest delays with why it takes so long, this 8-week turnaround. You only get one shot at this. That's just fairness. So one patient gets one shot. If you have if you're unlucky to have 2 cancers or 3 cancers, I think we can all agree as a community, you get 2 shots or 3 shots. But if you have 1 cancer, you get 1 shot. If we stuff it up, obviously, then you get another shot at it. So if the test comes back and it's reliable, it's a 1-shot thing. We don't do repeat testing. And sometimes the samples don't tell us much, right? This is just this thing again. It's really important. I can't stress this enough. These are 2 completely different things. One, you inherit genetics that might leave you at risk of pancreas cancer, and then you can transmit that to your children. Another one is where it's nothing to do with mom and dad or your kids at all. It's only to do with the cancer that's there, that's different to you. That cancer is not the same as you. It has different genetics to you. I want to find out what those different genetics are. There's just a little thing about trials. So some of you will probably think that I'm trying to experiment on you with like Donald Trump bleach and anti-helminthic weird potions. A lot of people think that trials are kind of like traveling to some civil war region where you might have a good enough time sometimes, but it's so dangerous and no one knows what they're doing, and I'm a complete guinea pig and it's all awful. I want to be very clear with you. The vast majority of trials that we do now are like going to Bali, right? This nice little couple here to the right. Now, he could get Bali belly and she could get overcharged at the checkout, and they could be stuck in traffic, right? So yeah, them kind of thing that can happen, but there's not going to be a civil war in Bali, right? I know a huge amount of what these experimental drugs do. We probably already used the drug in about 1,000 patients before in a different cancer type. And yeah, okay, it's an experiment, but it's really not as much of an experiment as a lot of people think. And, we view this as a standard of care. to be on trial. It's a variant of standard of care, and I don't want you to be too worried about a trial. So these are we've sequenced 1,575 pancreas patients so far. So pancreas cancer patients are a big part of our group. There's this rare subtype of pancreas cancer called ampullary, and we've done 85 of them. That may not seem like much, but that's the highest in, there's no publication that has higher than that. And we've got a couple of pancreatic neuroendocrine tumors as well, about 81 or so. And so the top genes there, you can see this kind of pink list. So everyone seems to have pancreas, seems to have KRAS, this thing called KRAS, right? KRAS. That seems to be really, really super common. So 1,327 out of 1,575 patients are having KRAS. There are a couple of other genes there, and you can see that it kind of starts to drop off fairly swiftly. And the next one down the cab that's targetable, that there's a drug that I can give, is something called MTAP, and that's in 16% of patients. So that's still pretty high. And then there's something else called BRCA, which is 6%, and something called ATM, which is 4%. Right. And if you added up all those, let's add up the 16%, 6%, 4%. You're now looking at 36% of the community just with those three genes, and they all have targets. 36%, that's a third of all pancreas cancers coming into this program having at least one target they can treat. And that's not including some of these KRAS mutations are also targetable now as well. So that's not including that. And I'm deliberately not including the weird and wonderful at this point. There are lots of weird and wonderful. You could have a 1 in a million gene that I can target, and it's really good. If I added up all them, that's about another 5-10% of the population. So this is, you can see you're rolling the dice. You're not always getting the win, but it's a pretty decent odds to get something out of this. I just want to focus on KRAS because it's so important in pancreas cancer, and they're just the different subtypes of this gene. G12D and G12V are the big players there. G12D is now a targetable event. It's very early, right? Super early. Our program has meant that we have over-recruited to the trials of this space and have led to the opening of 2 other KRAS G12D trials in Australia that weren't even going to open here. And that's accelerated recruitment so much that they're already now thinking of going to phase 2. So within like the next year or so, they think they're going to move to phase 2. There's something called KRAS G12C. It's only about 1.6%, so it's not very common. But if you have that, I can give you a tablet and you'll live for double the length of what you're going to live at a really tolerable quality of life, a really good quality of life. So if I find that in you only 1.6% of the time, I'm really happy to find that. That makes a major difference to your outcome. And so this is just me kicking down the door of KRAS because I hate it. It's a bloody horrible gene. And so that's 1%. What 1% plus of our cohort is G12C. These are that's just a little bit of evidence, right? You don't have to worry about this too much. And G12D is a much bigger percentage of our KRAS population. It's about a third of our population. We're working pretty hard on it. We're getting 20 to 30% response rates at the moment, and we're moving that up. What we're going to do is probably combine them and get a better bang for buck, right? That's our next step after this. And then those response rates will come right up. Now, I did a little AI thing here. It's nice, it's different, it's unusual. I couldn't actually get Kath and Kim so this is an AI version of Kath and Kim, but I said to you, most people are KRAS mutant. About 10% of people are not KRAS mutant. That is nice. And I mean it nice. It's different and unusual. It's nice insofar as there are a lot of, I start going, oh, this person is KRAS, doesn't have a KRAS mutation. They could have some pretty strange stuff. And the majority of the strange stuff that they could have, I can target with drugs that are really effective. Right. So again, it's a small percentage, but you can see how I'm adding all of these cases up. I'm getting a little bit here, a little bit there, a little bit there, and all of a sudden I'm getting a big section of the community. And they're just an example of all the different targets, all that big line of things. Don't worry about the words too much, but I do want you to know that there's something different about being wild type, they say, not having KRAS. KRAS means 90% of people have KRAS. Now it matters what type of KRAS you have. And it also definitely matters if you don't have KRAS, because there are lots of targets in that population. There's this other thing, and you may have seen this, this data around in pancreas cancer. BRCA2, I reckon at least half of you would have heard about this. The BRCA, there's something about BRCA and pancreas cancer, some kind of connection there. This gene BRCA2 as well as ATM is pretty common. It's about 10% of people plus 10% plus of people having either BRCA2 or ATM. These people, even with chemotherapy, I can give them a different chemotherapy options. So they don't even have to go to a trial. I've got a different chemotherapy option. So if I find that in 10% of my patients, I have an extra chemotherapy option I can give them that I wouldn't be able to give them otherwise under the PBS for free. They don't have to go to trial. There are also trial drugs on top of that. So they have that option and they can go to a trial to do other drugs, but they've got a double win. And then this MTAP thing, MTAP is it's a little oh, sorry, just before I talk about the MTAP thing, this ATM and BRCA, what is it? I won't go into too much detail, right? But what's going on is that the cancer happened because a gene happened, right? And usually it's 2 or 3 different genes. One of the genes was this list of BRCA or ATM. And so what goes wrong is that gene means that the cell is trying to copy itself and make a good copy of itself to grow and make new daughters and get bigger and bigger, right? It's trying to multiply itself, but it's not doing a very good job of replicating the code. So there's a set code that it has to go, okay, well, I'm going to put the roof over here and the door is going to be this way and the window is going to be there, right? And it's trying to follow the code, but it's getting a bit scrambled because of this gene. I can give it a drug where you see the fella there, the guy on the left, he's kind of just about holding his own. There's a lot of code for him to read. It's all a bit jumbled. He's not doing a great job of it. I can put in a great big siren of a drug into his office and go like that and put loads of clocks and bells and completely confuse him so that he cannot write that code anymore. And then the cancer cell dies. And that's what's called a PARP inhibitor, right? And I put the siren in because I don't know, PARP, right? He's getting annoyed. He's getting overly confused. There's too much code that he has to read. And we've a lot of trials in this area. And we've got kind of generic trials for that whole gene family. But what's very exciting, we're developing specific gene inhibitors. So just ATM inhibitor gene or just an ATR inhibitor drug. And they're looking very interesting. We're starting to experiment with combinations in those drugs too. So this is definitely one to watch for someone that's for pancreas cancer. This is something to watch. And MTAP loss, I won't confuse you, but you look at 16% and there's 8 trials in Australia. So it's pretty big news. This is an example of the weird and wonderful, right? So occasionally you can just get, this is a poor, unfortunate 24-year-old lady with pancreas cancer. And we did her sequence, and we found this really weird and wonderful fusion. It's not common at all, but it's got a great drug, and then there's another drug. And so what we've done, we've given her one drug, she developed resistance to that. We found that resistance, we gave her another drug, and she's still going on. She still has cancer, of course, but she's at least looking at a couple of years because of this, because of trying to find this. Now, who should do it? Well, as far as I'm concerned, everyone's on the call should be doing it. I do think you'd really want to do it if it's a strange case or a rare case, but I just advise everyone, really, if they've upper GI cancer, better to do it now. I want you to have an idea of the genes. So, what was my KRAS? What was my BRCA? What was my MTAP? Right? I want you to know these big player genes. These are important genes for you to know with pancreas cancer. That's what I want. There's bajillion genes. You saw the list of genes, you get confused. I just want you to know those genes. They're important to a pancreas cancer. Make sure that they were checked. And how do you have the conversation? Well, don't do it in the first meeting. I think you have far too much to talk about in the first meeting. Consider even making an extra appointment or a specific appointment, just staying quiet. Don't tell them about anything else. You've only got so much time. So just go, look, I'm good enough. Make sure you are good enough, right? If you're not good enough, don't do it then. Maybe wait. But if you're good enough, you're not really going to talk about too much. Maybe just stop. Don't say anything else. They've only got so much time. Don't waste the time with things that you don't need to talk about if it's a good time. And just say, look, I don't want to talk about anything else. Everything's grand. I just want to talk about this. They will be very keen if you're willing, right? And you often have to do a biopsy again. So I want you to, if you're interested in this program and there's not enough tissue, well, you need more tissue. So you would need a biopsy. And that's, if you don't want to do that, well, there has to be enough tissue there left. And if there isn't enough tissue, well, you can't do the program. So, they might find that difficult to have that conversation with you. So knowing that, basically passion is key. And then if you've got maybe a bit more of a sluggish or a busy clinician, you could get the allies to do it for you. Talk to your nurse specialist. This second opinions privately. I believe if you approach anyone in the right way, you don't usually have to do something like this. It's really rare that you've got a completely obstinate oncologist in front of you. Normally, they're just a bit busy or distracted or something like that. They normally don't mean ill. If you can come in there with a vision and a plan, I suspect you're not going to have much trouble here at all. And this is just to finish up. We've lots of cool stuff. Don't worry about the names and what I'm talking about there, but there's loads of cool things along the way. I'm making sure that pancreas cancer get their own on this as well. That we're focusing on pancreas cancer and upper GI as a group of particular special interest to make sure that they're supported. And there's a load more new trials. Another really cool thing is this tele-trial business where you don't even have to traipse all the way down to 3 hours down the road. They can just do it on like we're doing now, virtual, right? We've been integral. We've actually, believe it or not, I'm name dropping again, but we did the world's first in human trial via telehealth. No one had done it before. And a couple of years ago, I did the world's first phase 1 tele trial in the world. And we published on that as well. And so Victoria in particular and Queensland in particular we've literally been world leaders in this. And I'm looking forward to this being a lot more common because I think we get a lot more trial patients as a result.